Everyone to Symptom Management in Patients with ESRD with Dr. Holly Koncicki. I'm Sherry Sliwa, Coordinator for the Coalition for Supportive Care of Kidney Patients. It's our sixth webinar event in our series on supportive care and nephrology. These webinars complement a series of articles in nephrology news and issues. Dr. Koncicki's article will be the cover story in their October issue, so please be on the lookout for that. Before we begin, just a few housekeeping items. For clear reception, attendees' lines have been muted. We encourage questions throughout the webinar and ask that you use the chat feature on the right side of your screen to submit questions. Submitting a question via chat, type your comments and questions into the text box, choose All Participants, and press Enter. We will attempt to answer all questions during the presentation as we may not have time for questions at the end of Dr. Koncicki's presentation. The webinar. Also, as you're leaving the closing out the screen of the webinar, you should receive a pop-up evaluation. We greatly value your feedback. Today, our moderator is Dr. Alvin Moss. This is a professor of medicine in the sections of nephrology and palliative medicine at the West Virginia University School of Medicine. He serves as chair of the Coalition for Supportive Care of Kidney Patients. Dr. Moss is also co-principal investigator on the Pathways Project, a Moore Foundation-funded project to integrate supportive care into the treatment of patients with advanced chronic kidney disease and end-stage renal disease. I'm now going to turn it over to Dr. Moss.
Thank you, Sherry. It's a pleasure to introduce Dr. Holly Koncicki. Holly is sort of in a new subspecialty niche of nephrologists. We know of transplant nephrologists. We've heard of interventional nephrologists, but she is a palliative care nephrologist. I think I personally know 10 or 20 palliative care nephrologists, and it seems like every few months I'm hearing or learning or meeting another one. Holly completed her medicine residency and integrated nephrology and palliative medicine fellowship at Mount Sinai Hospital in New York. She's currently an assistant professor at the Icahn School of Medicine at Mount Sinai, where she serves as an assistant director for the Integrated Nephrology and Palliative Care Fellowship. And she's established a renal palliative care outpatient practice. She has presented at several national and regional conferences, including those at the American Society of Nephrology, the Renal Physicians Association, and the American Academy of Hospice and Palliative Medicine. She has multiple publications on topics including pain management, communication, and decision-making in the elderly with advanced chronic kidney disease. Her major interest areas include prognostication and educational renal fellows regarding the integration of palliative care into the care of patients with kidney disease. So Holly, let me turn it over to you. Thank you very much.
Thank you. I really appreciate the invitation to be with you today and to speak on a very important topic, which is symptom management in patients with end-stage renal disease. So by the end of today's webinar, I hope that the attendees will be able to identify commonly encountered symptoms experienced by dialysis patients, to describe treatment options and understand limitations and evidence, and to understand that symptoms are often not solitary and how the interplay between them can affect a patient's quality of life. Often the decision to start dialysis is based upon symptoms. While there are some absolute indications, which we all know, hyperkalemia, intractable volume overload, or uremic pericarditis, often the decision to start is due to the presence of uremic symptoms or in an effort to avoid such symptoms from occurring. The evidence regarding the effect that dialysis has on these uremic symptoms is mixed. So I just wanted to go through some commonly encountered uremic symptoms that may cause someone to decide to start dialysis. So malnutrition is one of the most common symptoms for which providers decide to start dialysis, with one study showing that 72% of providers said that this would be a reason to start early. And in the year after dialysis initiation, we do find that nutritional parameters improve. In terms of fatigue, it's a common symptom, but there seems to be inconsistent results with the effect of dialysis, with one large study showing that after starting dialysis, 24% of patients reported improvement in fatigue, whereas an equal amount reported worsening of fatigue. Cognitive impairment often we see will decline with progressive chronic kidney disease, and this decline will continue with dialysis. Neuropathy seems to go unchanged after starting dialysis, and pruritus actually seems to worsen in our dialysis patients. So these symptoms will persist in our patients. This was a large study that assessed physical and emotional symptoms in 162 patients on maintenance dialysis. It used the Dialysis Symptom Index to assess 30 symptoms and also evaluated the effects on depression and quality of life scores. So the most prevalent symptoms that we're seeing, with over 50% of patients reporting feeling tired or having a lack of energy, experiencing pain in the bones or joints, and also dry skin and itching. Over 40% of patients describe sleep issues, dry mouth, and muscle cramps. In terms of severity of symptoms, the most severe symptoms described by these patients were GI symptoms, pain, itching, psychological symptoms such as worrying and anxiety, sleep, and sexual concerns. So for the remainder of this session, we're going to focus on the following commonly encountered symptoms, including pain, pruritus, depression, fatigue, sleep disturbances, and restless leg syndrome. And I'm going to introduce you to several patients during this session to kind of show how we would manage a patient in these situations. So the first patient is Lisa. Lisa is a 50-year-old female with end-stage renal disease on hemodialysis, secondary hyperparathyroidism, diabetes, hypertension, peripheral vascular disease with a below-the-knee amputation. And she often expresses anger regarding her below-the-knee amputation, frequently describing that she was robbed of her limb. She complains of severe joint and back pain, which has been attributed to renal osteodystrophy. The pain impairs her ability to carry out some of her daily activities and her ability to work. And also because of pain, she's been cutting treatment short once per week. She often does not meet her dry weight and has had several admissions for fluid overload. Her primary care doctor asked that she follow back up with you, her nephrology provider, in regards to management of pain, since you see her more frequently. Now, I think that we would agree with most of our patients when they tell us that dialysis is a big pain in the you-know-where. But it's not just about pain with cannulation. When surveyed, we see that approximately 20% of our patients will have multiple causes of pain. The most common cause of pain in our dialysis population is musculoskeletal in nature, though we also see pain related to the dialysis procedure, such as pain with cannulation, peripheral neuropathy, peripheral vascular disease, and some other causes. Chronic pain is defined as pain that's present for greater than 3 months duration and is more prevalent in the dialysis population as compared to the general population. There also seems to be some correlation with dialysis vintage, and modality does not seem to have an effect on pain. Of those dialysis patients experiencing pain, close to 83% rate it as moderate to severe in intensity. Now, our ability as nephrology providers to recognize and manage pain can positively impact healthcare on numerous levels. On a patient level, uncontrolled pain has been shown to negatively affect quality of life. In addition, patients with uncontrolled pain have high rates of depression, insomnia, a poor ability to cope with stress, an increased perception of burden of disease, a decreased perception of social support, and decreased life satisfaction. On a dialysis level, severe pain is independently associated with abbreviated treatments, a 20% increase in hospitalizations, and a 50% increase in emergency room visits. And it's also associated with an increased likelihood to withdraw from dialysis. So in terms of approaching pain management in this population, we want to assess pain and try to determine the etiology of the pain. Follow the World Health Organization analgesic ladder for guidance, and set expectations for treatment. And it's important to set expectations with patients that pain, and for some symptoms, that the symptom may not disappear completely, but rather to discuss to determine what threshold of pain would be tolerable so that the patient can function normally and enjoy his or her quality of life. After initiating treatment, we want to follow up and monitor for side effects. Now, in terms of assessing pain, dialysis patients are somewhat fortunate in the sense that there is an interdisciplinary team that cares for them. And I think that to do a thorough pain assessment, this team really has to be involved. The nurses, techs, social workers, and other providers can all take a part in assessing someone's pain. And we know that pain is not experienced in a silo, but rather pain can worsen other aspects of a patient's life, just as other aspects of the patient's life can influence their interpretation of pain. And I wanted to review this concept of total pain, which again I think can also be described or applied to other symptoms that we're going to discuss. And it takes into account variables that will influence how a patient experiences and perceives pain. So Lisa has the physical aspect of pain in the joint and bone. And this can lead to psychological symptoms, so anxiety, depression, feeling robbed of her limb. It's estimated that depression and pain coexist, with some studies estimating it being as high as in 70% of patients. Now, these psychological symptoms can also have an effect on her social aspects of her life. She can't work, she's having loss of finances, loss of her social status, and this can also contribute to her spiritual pain, anger about having a below-the-knee amputation, and searching for meaning. Why is this happening to me? Why am I having pain? Why am I on dialysis? And I think that physical and psychological pain are where we as providers can have the most impact. So in terms of our approach to pharmacologic therapy, the World Health Organization has this ladder framework for drug selection. And it was initially developed in the general population, though it has been validated in patients with kidney impairment on dialysis, with 96% having adequate analgesic at 4 weeks, and also showing improvement in other aspects of their life, such as better sleep, improved function, better exertional tolerance, and a better ability to tolerate dialysis. Now, this is a stepwise approach that's based upon the severity of pain. So step 1 is your non-opioid analgesics, such as NSAIDs and acetaminophen. And it's recommended to start with this for mild pain. Step 2 is for moderate pain and includes using opioids such as tramadol, low-dose oxycodone, and low-dose hydromorphone, also known as Dilaudid. Step 3 is for more severe pain and includes the use of some longer-acting medications, such as fentanyl patch. And step 4 has been added in recent years, which includes interventions such as nerve blocks and epidurals. And this is something that I actually tend to investigate very early on in my patients with chronic musculoskeletal pain, because I find that they're sometimes able to avoid an added pill burden of medications. Now, during any of these steps, it's encouraged to use adjuvant therapy or alternative medications. There are some limitations to this ladder approach. So this ladder approach, again, the treatment decisions are based upon severity. And on severity alone means that a lot of patients may be initiated on opioids, which may not be the most effective, especially for chronic pain. And additionally, there's added concern recently with the opioid epidemic. So not only are providers concerned about prescribing these medications, but patients may be hesitant to take. And it also doesn't take into account the cause of the pain. So neuropathic pain may be approached differently than musculoskeletal pain. So in terms of the non-pharmacologic therapies that you can use, there's cold to reduce inflammation, heat to alleviate symptoms of muscle spasm. Alternative therapies like music, massage, acupuncture, and cognitive behavioral therapy all have small studies that have shown at least a trend towards benefit and with very little risk. The major limitations of these therapies will be access to care. So for cognitive behavioral therapy, it may be financially prohibitive or time prohibitive. So there are some free apps here that patients can pull up on their phone and would be able to use. Topical agents are good for either monotherapy or in combination, and this is helpful if you are concerned about systemic analgesia or if the pain is localized. So lidocaine patches can be helpful. There are lower dose capsaicin creams or ointments, though there is this higher dose patch that's not FDA approved but has been shown to be potentially promising in treating neuropathic pain. So this was a study of 20 dialysis patients that had neuropathic pain from limb ischemia. And after one application of this patch, there was a significant reduction in pain scores at 12 weeks, with a median decrease in opioid use by 50%. There's also topical NSAIDs that can be used and can be helpful. For pain that's related to the hemodialysis access and cannulation, you have your lidocaine and prilocaine creams, which you would apply about an hour before expected cannulation, or an ethyl chloride vivacoolant spray, which you can use seconds prior. Now, in terms of the systemic therapy, we have NSAIDs. In the era of the opioid epidemic, where there's heightened awareness about the use of opioid medications for pain, NSAIDs would be a reasonable option, except for the fact that we're taught from day one of renal fellowship to avoid NSAID use. So typically, acetaminophen is usually our preferred non-opioid analgesic. But I would argue that there are certain populations with renal disease where NSAIDs should be considered as a reasonable and appropriate option, including in dialysis patients. So what's the concern about NSAIDs? So in our chronic kidney disease patients, we're worried about expediting renal decline. In our dialysis patients, we're not as concerned with that, though maybe there's some effect on residual renal function. But there has been shown to be an increase in blood pressure with the use of NSAIDs, and this will vary based upon the medication used and also the antihypertensive agents that the patient's on. So typically, an increase in blood pressure between 3 and 5 millimeters of mercury have been seen with NSAID use, and it appears that ibuprofen actually has the greatest effect on systolic blood pressure. There's also a concern for volume retention, but I haven't been able to find any studies that really look at the clinical significance of this volume retention. There was a study that described some association of NSAID use with risk of stroke. So in about 1,200 dialysis patients with stroke, there was a 30% increased risk in those patients who had used NSAIDs 30 days prior. That being said, in our dialysis patients with musculoskeletal pain specifically, I think that NSAIDs would be reasonable for a short-term course as long as there's close monitoring of blood pressure and volume status. So the next step of medications is that step 2. So now we're getting into our opioid medications. And the preferred medications are hydromorphone, oxycodone, and tramadol. And really these are preferred based upon mostly low-quality evidence of case reports or the pharmacology of the medications. Hydromorphone will have a prolonged half-life in renal disease, so it is recommended that the dosing interval be increased. Whereas you may dose this medication every 2 to 4 hours in someone with regular renal function or normal renal function, you would consider increasing it to every 6 or 8 hours in someone with renal dysfunction. Some of this medication will be removed with dialysis, so you can encourage patients to take the medications after dialysis. Oxycodone commonly comes in a combination pill with acetaminophen. Trademark name is Percocet. And the use of combination pills should be avoided or used with caution when you're acutely titrating, because the maximum dose of the medication that can be used will be based upon the daily allotment for acetaminophen of 4 grams. So in these cases, you may want to dose the acetaminophen separately and then prescribe oxycodone. Now, oxycodone, like hydromorphone, has an extended half-life in renal disease. So again, you would want to increase the normal dosing interval. This medication also seems to be dialyzable. Short-acting tramadol is the last medication that's considered preferred. The extended release formulation is contraindicated in patients with renal impairment. Active metabolites are cleared by the kidney, and dialysis minimally clears the medication, so there is some concern for accumulation of this medication and metabolites. So again, you would want to increase the dosing interval, and whereas normal dosing in someone with normal kidney function would be between 50 and 100 milligrams every 4 to 6 hours, the maximum dose in dialysis patients that's recommended is 50 milligrams every 12 hours. So some people will say that tramadol is a tramadont in renal patients. The last step is are step 3 medications. So it would be higher dose oxycodone or hydromorphone, or medications such as methadone and fentanyl. Methadone is a great medication to use in our dialysis patients because the plasma levels are near normal in dialysis patients as compared to those patients with normal renal function. And that's because there's increased GI excretion of this medication. Methadone is unlikely during dialysis, but you do need some special training for methadone dosing, so patients would require a referral if you thought someone would benefit from this. Fentanyl is a long-acting medication. It comes in a transdermal patch, and it's not to be used for opioid-naive patients or for acute titration. This is for someone that's on a stable chronic pain regimen that you want to transition to something that's longer acting. And fentanyl is reportedly well tolerated in renal failure, and it's not likely to be dialyzable. So in our patient, Lisa, we could start her with a short-acting medication. We would want to avoid combination medication. So, to start her on acetaminophen or an NSAID around the clock, and then also can add on a short-acting opioid to be taken as needed. So in this case, we started oxycodone 5 milligrams every 6 hours as needed, which she actually responded quite well to. And of course, you want to monitor for side effects. The big side effects being sedation, which will improve the longer she's on the medication, and constipation, which does not get better. So patients with this will need a bowel regimen. For neuropathic pain, our patients actually have a lot of reasons to have neuropathic pain. There's systemic processes like diabetes, amyloid, uremic, neuropathy, viral syndromes, and also anatomic changes that can cause neuropathy. So about 28% of dialysis patients will have carpal tunnel syndrome, often in the arm that has the access, which is thought to be due to increased hand volume and venous pressure from the vascular access. Anywhere from 40 to 60% of patients have been described to also have ulnar neuropathy, which again is thought to be due to pressure on the cubital fossa in their access arm during dialysis treatments. So what are our go-to medications? So gabapentin and pregabalin is what is most commonly used, though only pregabalin has FDA approved for neuropathic pain from diabetes. So these medications are used off-label for neuropathic pain, pruritus, and restless leg syndrome. In terms of the dosing guidelines for gabapentin and pregabalin, it's going to vary a bit on where you look and how comfortable the provider is. But usually we would recommend starting with, for gabapentin, 100 milligrams post-dialysis with a maximum dose of 300 milligrams daily. For pregabalin, you can start at 25 milligrams post-dialysis with a maximum dose of 75 milligrams daily. Second-line agents would be your tricyclics, antidepressants, your serotonin norepinephrine reuptake inhibitors. But for all of these, again, you want to start low and titrate slowly. Usually I would give it about a week to assess symptoms and how the patient's doing. Now, when discussing the use of these pain medications, there are recent studies which have come out which has made us appreciate that we have to take extra caution in giving these medications. So there were 3 major studies. The first 2 were very similar, looking at ESRD data of 140,000 dialysis patients and the risk of altered mental status, fall, and fracture in patients given gabapentinoids or given opioids. So the first study looked at patients who received gabapentin or pregabalin, and the majority of these patients were using these medications for, again, off-label uses for symptoms such as neuropathic pain, pruritus, and restless leg syndrome. The study found that at low doses, there was an increased risk of falls, and with increasing doses, there seemed to be an increasing risk of altered mental status, falls, and fracture, with those patients who were taking greater than 300 milligrams per day of gabapentin having the highest risk. And again, this is outside of the recommendations for dosing in this population. So what they found was that gabapentin was associated with these higher risks, even in lower doses, and pregabalin was also associated with higher risk of altered mental status and falls. So we have to use these medications carefully and thoughtfully in our hemodialysis patients, and more research is really warranted on finding the appropriate dose for these patients. So the same study was done looking at opioid analgesic use. So all of the opioids that were being used was converted into morphine equivalents. So it was really just to look at the total, first to look at the total daily dose of opioids that the patients were taking. And they found that even at the lowest dose of use, there was an increased risk of altered mental status falls and fracture with an increase in dose. We then looked at the medications specifically and found that though the preferred medications had some risk of altered mental status fall and fracture, so for hydromorphone, fentanyl, and methadone, there was an increased risk of altered mental status, and hydromorphone did have a very small risk of fall and fracture. It was much lower as compared to the medications which we avoid in our end-stage renal disease patients, so morphine and codeine. So specifically, codeine had, a very high risk of altered mental status, fall, and fracture. But even our preferred medications like oxycodone and tramadol, there was an increased risk in this population as well as these outcomes. So the conclusion was that opioid use, even at low doses, can be associated with adverse outcomes, and different opioids are associated with variable risk. So perhaps when choosing, hydromorphone may be preferred over oxycodone or tramadol based upon what we found in this study. The last study looked at morbidity and mortality and opioid use. So it looked at a larger number of 270,000 hemodialysis patients and found that the majority of patients had at least one opioid prescription over the course of every year. It looked at mortality and risk of hospitalizations and with dialysis withdrawal. Now, the most common opioids prescribed in this study were oxycodone and tramadol, so those are preferred, but then also hydrocodone, which is in the codeine family, and propoxyphene, which is actually off the market. So not all the medications that were being prescribed were preferred medications. This study also found that even with just short-term use of opioids, there was an increased risk of death, dialysis discontinuation, and hospitalizations. When they looked at higher doses of the medications that were used chronically, they found that with increasing dose, there was also an increased risk of these three outcomes. So for example, in patients that were taking more than 50 morphine equivalents a day, they had a 39% increased risk of death and a 38% increased risk of hospitalizations. So they concluded that all opioid medications were associated with increased mortality and most were associated with morbidity, and that higher doses were correlated with an increased risk of death. So I think that these studies are important to know because it supports the use of preferred medications and dosing and encourages thoughtful decisions around prescribing. But there are limitations to the study, to all the studies. There are observational studies. The studies do not show causation, so the patients weren't dying because of opioids. So the question is, were there confounding variables that, though tried to be controlled for, were not controlled for? Did these patients have more severe disease, which caused them to need opioid medications and put them already at a baseline risk of higher mortality because of this more severe disease context? So in summary for pain, the preferred medications include hydromorphone, oxycodone, and maybe tramadol, fentanyl and methadone, and then gabapentin and pregabalin for neuropathic pain. We always want to start low and titrate slowly, monitor for efficacy and side effects, and have a low threshold to refer if you're concerned about patients' aberrant behavior or if they have hard to control symptoms. So I want you to also meet Patricia. So Patricia is a 59-year-old female with end-stage renal disease on hemodialysis, diabetes, hypertension, chronic pancreatitis, and frequent hospitalizations related to dialysis noncompliance, volume overload, and hyperkalemia. So while you're rounding, she complains of intense pruritus all over her body. She does not use a moisturizer, uses a generic soap, and showers daily. The itch keeps her awake at night, and sometimes she's so tired that she's unable to come to dialysis the following day. She's also terminated treatments early due to itch, and even has gone to the emergency room for evaluation of what she calls unbearable itching. In terms of her exam, she has generalized just dry skin with some excoriations, but no rashes or open lesions. She's tried diphenhydramine, which is also known as Benadryl, and hydroxyzine with little effect. So pruritus has been reported in over 40% of dialysis patients, though some studies actually suggest the prevalence is as high as 80%. The presentation is usually daily or near daily itching, discontinuous, non-dermatomal areas, but bilateral and symmetrical. Physical findings are usually limited unless there is a secondary dermatologic condition. And there's little consensus about exacerbating and alleviating factors. So the dialysis outcomes and practice pattern studies, which was a large observational study, actually showed similar prevalence of pruritus in hemodialysis and peritoneal dialysis patients. It also found that patients with moderate to extreme pruritus were 4 times more likely to feel drained, 3 times more likely to have poor sleep quality, and 1.5 times more likely to be diagnosed with depression. They also had a 17% increase in mortality compared to patients without pruritus. So why do we see pruritus in our patients on dialysis? So there's several theories. The first is that there's a decreased hydration of the skin due to atrophy of sebaceous follicles and sweat glands and development of microangiopathy in the skin. There's also an opioid theory, which is similar to that of why someone would develop cholestatic pruritus. That in urea or in kidney disease, there's enhanced stimulation of mu receptors, which will increase itch, as compared to the kappa receptors, which will decrease itch. There's an inflammatory theory as well, in that ESRD is a chronic inflammatory condition. And when they compare dialysis patients with pruritus, they find that they have higher levels of inflammatory markers like ferritin, higher levels of CRP, interleukin-6, interleukin-2. What does not seem to drive pruritus is actually histamine. So uremic pruritus is not considered to be histamine mediated. There have been functional MRI studies where itch is stimulated by histamine pathways and non-histamine pathways, and found that uremic pruritus fits more with the non-histamine pathways. So our approach to these patients is to first make sure that there is no secondary dermatologic condition going on. So clues would be skin lesions, bullous lesions, ulcerating lesions, or finding of other lesions on the skin. For dialysis patients, we want to make sure that they're getting adequate clearance with dialysis, and if not, to adjust the prescription accordingly. And also, studies have suggested that elevated calcium and phosphate and secondary hyperparathyroidism can contribute to uremic pruritus. So using medications to control these factors is important. There are several case reports of hard to control or refractory pruritus in the setting of secondary hyperparathyroidism, where following parathyroidectomy, there was almost complete resolution of the pruritus. So after we optimize the biochemical parameters and the dialysis prescription, we can also recommend using emollients. So we already said that we think that part of the reason that patients develop this is because of drying of the skin. So several case series suggest and show benefit in using emollients at least twice per day in improving itch. UV phototherapy has also been described. It was initially evaluated in the 70s, where patients were given half-body treatments, and it showed improvement. In the 80s, there was a study that looked at UVB therapy and actually showed that afterwards there was a decrease in phosphorus deposition in the skin and benefit in the itching that the patients experienced. There is limited long-term evidence of UVB therapy, so we don't know about long-term outcomes. Acupuncture is a non-pharmacologic ways to manage this, which actually has shown benefit in some small studies. So this is a study of 40 patients with refractory uremic pruritus who either had acupuncture or a sham procedure 3 times a week for a month. And at baseline, the lab values were not different between the groups. So what they found here was that you have your pruritus scores on the y-axis and time on the x. Both groups started with scores that were high. So in the acupuncture group, which was group 1, they started with a score of 38. At 1 month, the pruritus had improved with their score down to about 17, whereas in the sham group, the relatively unchanged and the severity of pruritus persisted. And at 3 months with acupuncture, it seemed as though the acupuncture group actually maintained their benefit in terms of alleviation of the itching. In addition, the acupuncture seemed to also reduce sleep disturbance as well, and there were minimal adverse effects to this. In terms of pharmacologic therapy, what's not preferred is antihistamines, though it's what is commonly used, especially in our dialysis units. There's limited efficacy in this. The only thing that it does do is it is sedating, so patients may not feel the itch if they are asleep. The preferred medications are actually the gabapentinoids. So again, gabapentin and pregabalin, though they are not FDA approved for pruritus. Again, the use of these medications, the evidence is limited, mostly with small case series or case studies. So I thought this was actually like a neat study that showed the efficacy of gabapentin in treating pruritus. So this was a double-blind study in 34 hemodialysis patients with refractory pruritus who were given 100 milligrams of gabapentin after dialysis for 4 weeks, followed by a washout period, and then placebo for 4 weeks. And they used a visual analog scale, which is here on the y-axis of 0 to 100, with 100 being severe, to evaluate the severity. And they said that a score that decreased by 50% was effective. So after 4 weeks of treatment with gabapentin, the score came down to around 6. After a 1-week washout period, the score increased to 15. And then at the end of the 4 weeks of placebo, the score increased again to 80. So there was a significant reduction in pruritus with gabapentin. Newer studies are looking at the opioid receptor modulators, though there are conflicting results. So these medications are being evaluated because, as we said earlier, there is this theory of an imbalance between the pro-itch mu receptor and the anti-itch kappa receptor. So naltrexone is a mu opioid antagonist in a small study of 15 patients who were given 50 milligrams of oral naltrexone for 7 days. There was almost complete resolution of pruritus. However, subsequent studies don't show the same benefit. So unclear as to if this will be efficacious. A kappa receptor agonist was also looked at. There was a meta-analysis of 140 patients who received this medication IV 3 times a week for 2 to 4 weeks, and it did show reduction in itch. And another study of over 300 hemodialysis patients that were given the medication orally that did show a significant reduction in itch at 7 days as compared to placebo. So while these medications are promising, there isn't a lot of clinical data or experience to recommend it as a first-line treatment yet. So in terms of the approach to treatment for our patient, we noted that she had adequate dialysis, her calcium and phosphorus were pretty well controlled, and we had recommended her to use aggressive skin moisturization. We started gabapentin 100 milligrams per night, and she had near resolution of her symptoms. So we just have been maintaining her on that. If she was not responding to gabapentin, we would increase the dose, but then would maybe try some other therapies such as acupuncture, UV phototherapy, or perhaps considering those opioid modulators. Next patient I want to introduce you to is Kim. So Kim is a 30-year-old woman with lupus nephritis who's progressed to ESRD and now on dialysis. And she's admitted with a lupus flare and pain. The team informs you that she seems sad recently, and the dialysis nurses note that she's often tearful during her treatments. And during screening, you determine that you think that she fits the criteria for depression. She agrees and asks if there's anything to do to help. Now, it's estimated that near 30% of patients with chronic kidney disease or end-stage renal disease meet criteria for depression, which is higher than that estimated of the general population of about 10%. Of those diagnosed, only 20% are treated. And this low rate of treatment is likely related to several barriers. There's barriers in diagnosis, as treatments of uremia and other comorbid conditions may overlap with the symptoms of depression. And also, if a patient is diagnosed, in terms of treatment, patients may be concerned over the stigma associated with being labeled as having depression and a very large pill burden, so may not want to add additional medications. But it is important for us to identify patients who may be depressed and to treat, as untreated depression is associated with several poor clinical outcomes, such as increased mortality, estimating to have a 40 to 50% higher mortality in dialysis patients with depression as compared to those without, a 12% increased risk of hospitalization and longer lengths of stay, increased cardiac events, and poorer adherence to medications, to diet and fluid restriction, and also associated with dialysis noncompliance. Now, Kudoki guidelines recommend evaluating for depression at dialysis initiation and at least biannually. And one of the easy tools to use, which is short, is the PHQ-2, where you ask these two questions. During the last month, have you often been bothered by feeling down, depressed, or hopeless? And during the last month, have you often been bothered by having little interest or pleasure in doing things? Now, there are some scoring categories where patients can actually rate how often they have these symptoms, whether it's several days, more than half of it, days per month, or nearly every day. But what we would consider positive screening for possible depression would be a single yes or a score of 3, of greater than 3. So in terms of how we would approach somebody that fits the criteria for depression, we would want to identify and treat contributing symptoms. So are they having uncontrolled pain or poor sleep? Antidepressant therapy with psychotherapy may be optimal. So in non-ESRD patients, combined treatment has been shown to have a greater success. In end-stage renal disease, these trials are limited, though cognitive behavioral therapy has been shown to improve depressive symptoms, also quality of life and fluid compliance. Medications can also be considered. So the preferred medication would be the selective serotonin reuptake inhibitors, or the SSRIs. These are hepatically metabolized, though some, such as paroxetine, will have a longer half-life in dialysis patients. Sertraline dosing, however, is relatively unchanged in ESRD, so that is often considered a first-line medication. Alternative options include your tricyclic antidepressants, though the use and tolerability of these is limited by anticholinergic effects, hypotension, and QTc prolongation. Two of the commonly used tricyclics are nortriptyline and desipyramine. Because they are renally cleared, there's no clear dosing recommendations, though some sources will recommend using 2/3 of the maximal daily dose as your maximum dose. So in these cases, you can start low at 25, but then not to go above 100 milligrams of nortriptyline and 200 milligrams of desipyramine. There's also the monoamine oxidase inhibitors and SNRIs, though those are not as preferred. So in this case, we could start with sertraline 25 milligrams and titrate up weekly for a maximum dose of 200 milligrams. After 8 weeks, if it's not working, an alternative agent can be tried, though you would have to titrate down the sertraline as you titrate up the second agent. So, depending on how comfortable you are, if you get to the point that you need to try a different agent, or after 2 agents you're still no effect, you might want to consider referral. The last patient I want to introduce you to is Joann. So Joann is a 72-year-old female with hypertension, diabetes, obesity, asthma, who was recently discharged with hypertensive urgency and progression of her CKD to now needing dialysis. She's admitted to the first shift of dialysis, and usually she helps to care for her grandchildren while her daughter goes to work. And she is in a lot of distress since starting dialysis. Her biggest concern is this extreme fatigue that she has after her treatments. She's worried that she's going to be unable to help care for her grandchildren because she's just so fatigued after. Now, fatigue is probably one of the most common symptoms experienced by our dialysis patients, with prevalence estimates ranging from 60 up to almost 100%, depending upon the study that you look at. It has been associated with a higher risk of mortality, depression, and lower quality of life, and there's likely many contributing factors to it. Patients have other comorbid conditions, side effects to medications, dialysis factors, nutritional factors, inflammatory conditions. One of the contributing factors may be that our patients have poor sleep quality. So 40 to 85% of dialysis patients in one study had reported having a sleep disturbance. Of 1,600 patients, Of 1,600 patients, 50% had reported trouble falling asleep, 50% had night awakenings, and 49% reported early morning awakenings. Poor sleep quality is associated with a higher use of prescriptions like antihistamines, antidepressants, narcotics, hypnotics, so other sedating medications that may help you fall asleep but not necessarily give you good quality sleep. And these patients also had a 16% higher mortality. There are associated symptoms and risk factors with poor sleep. The associated symptoms include pain, depression, and pruritus. And this study actually looked at the risk of sleep and the degree of bodily pain. And as you can see, with worsening pain, there was worsening sleep quality as well. So really looking at and addressing these symptoms are going to be important. So our approach is going to be to assess all the factors that could be contributing to poor sleep quality. So the framework would be to evaluate non-kidney disease factors such as other comorbid conditions, medications that they may be taking, lifestyle considerations and sleep hygiene, and then kidney-related or dialysis-related factors, as well as addressing other symptoms that could be contributing. So in terms of non-kidney disease factors, you want to look at other comorbid conditions. So does the patient have heart failure and they have orthopnea, which keeps them up at night? Do they have obstructive sleep apnea that decreases their sleep quality? Are they taking stimulants or steroids, or are they taking diuretics late at night and that's interfering with their sleep? Also looking at their lifestyle behavior. So are they taking naps during dialysis or after dialysis? Are they having caffeine late at night? For kidney disease factors, we know that patients on dialysis have worse quality sleep as compared to those patients with chronic kidney disease for numerous reasons that is listed here. They have less REM sleep, they have more wake time after sleep onset, higher limb movement, and longer sleep onset latency. Though the type of dialysis really seems to have variable effects, whether hemodialysis patients have better sleep than peritoneal dialysis patients. So why are our dialysis patients having such worse sleep? There have been studies that have shown that daytime hemodialysis may increase daytime sleep and also lead to decreased sleep onset and nighttime sleep. And this may be because of temperature changes with dialysis. During dialysis, there is an increase in the core body temperature, which may be related to cytokine release due to the cells interacting with the dialyzer, the heat load of the dialysis bath, and all of these will lead to cooling mechanisms, which can then enhance daytime sleepiness. There may also be a component of disequilibrium causing CNS depression, decreased alertness, and arousal. There may be physical and psychological stress response, and also biochemical contributing factors. So in patients with kidney disease, the nocturnal surge of melatonin is absent, as well as BUN and phosphate levels having shown to perhaps affect sleep latency as well. So what can we do in terms of adjusting the dialysis prescription to help with sleep quality? So there are variable results in if nocturnal hemodialysis is beneficial. Nocturnal dialysis does decrease sleep apnea, daytime sleepiness, and can improve sleep latency, though it seems to only really partially recover the effect on melatonin that kidney disease seems to have. Lowering the dialysate temperature to 35 degrees was associated with longer total sleep and shorter sleep latency. Exercising during hemodialysis was shown to be helpful and also improved some other factors, including restless leg syndrome and quality of life. Transplant actually has also been shown to reduce nighttime awakening or nighttime awake minutes, and subjective patients after transplant had better sleep quality, better quality of life, and better daytime sleepiness scores, though when they looked at nocturnal melatonin concentrations, those concentrations did not statistically change from prior to transplant. There are medications that we can use to help treat sleep, though information is really very limited because there's many knowledge gaps about the safety and efficacy of these medications. So in a study of about 3,700 patients, it looked at drug use and all-cause mortality, and it was found that 14% of incident dialysis patients used either a benzodiazepine or a non-benzodiazepine, something like your trade name is Lunesta or Ambien, and these medications were associated with a 15% higher mortality rate and a 3 times greater increased risk of fracture. So there's really limited evidence in the safety of these medications or the right dosing of these medications in our dialysis population. So really you would want to be very cautious with use of these medications. So what are alternatives? So there are antidepressants that can be used that have sedating qualities. Mirtazapine is an alpha-2 antagonist that is used for depression and anxiety disorder and has sedating properties. The clearance is reduced in renal dysfunction. So whereas someone with normal kidney function, you would start at 15 milligrams. In a dialysis patient, you can start at 7.5. Doxepine can also be helpful, though it has some anticholinergic side effects that may limit use. And then trazodone, which is my go-to medication for prescribing, you can start at 12.5 and 50 milligrams. And again, there's no real studies of trazodone in dialysis patients. So there are studies in cancer patients that show about 50% of cancer patients with these low doses had longer sleep times. And it seems to be well tolerated in patients that have cognitive impairments. The last class of medication would be your melatonin agonists and melatonin. So for the melatonin agonists, there's no studies looking at dialysis patients. But in melatonin, there have been some small studies that have shown as little as 3 milligram having improved sleep scores, improved sleep quality, and sleep efficiency. And though the effects were helpful up to 12 weeks, the benefits seem to have lost at a year. So unclear if melatonin may work good in the short term, but on a chronic basis, you may lose its efficacy. So in terms of sleep disturbances, you want to identify reversible problems or causes such as symptoms, comorbid conditions, medications, and changes to the dialysis prescription. Look at sleep hygiene. You can consider cognitive behavioral therapy again here. And then pharmacologic management, which you want to be cautious with the medications since there is limited data on them. Start low and titrate slowly. And I would consider trazodone and melatonin to be some first-line agents. So when you're speaking with Joann, she tells you that, when she falls asleep, she really has this urge to move her legs, and it won't go away until she actually moves her legs, and this is disrupting her sleep the most. So restless leg syndrome is exactly that. It's an urge to move legs that occurs during periods of inactivity and is relieved by movement. And it's not isolated to renal failure, though it's much more common in dialysis patients than the general population. It's been associated with a number of different conditions, such as low iron stores, low hemoglobin, certain medications, and also peripheral neuropathy. Restless leg syndrome has been associated with outcomes such as poor sleep quality, impaired quality of life, depression, and also patients with restless leg syndrome have been reported to have a 2 to 3 times increased risk of suicide or self-harm. So in terms of what to do for this, short daily hemodialysis has been shown to reduce the prevalence and severity of symptoms, so the number of patients needing medications did not change. Renal transplant actually had a huge improvement in days to weeks on restless leg syndrome. Iron supplementation did have some transient benefit. So in 25 patients that were given a gram of iron dextran or IV saline, there was some effect up, but then by 4 weeks, that effect was lost. And then exercise. So intradialytic exercise has shown improvement, as have other trials looking at exercise training. There are pharmacologic agents that can be used. So ropinirole or pramipexole are the 2 most commonly used agents. These agents take between 90 minutes and 2 hours to work. So usually you would recommend giving these medications about 2 hours before bedtime. In hemodialysis patients with restless leg syndromes, these medications have been shown to be of benefit. So of 10 patients, 9 of 10 actually showed response during the first week of treatment, with the mean dose being 0.25 milligrams. And overall, they seem to be well tolerated. Gabapentin and pregabalin, again, not FDA approved for this indication, but has also been shown to be effective in treating restless leg syndrome. So in 16 patients that were randomized with either gabapentin or placebo, they were given 6 weeks of treatment, a washout period, and then switched to 6 weeks of placebo. 11 of the 16 patients did respond to gabapentin, so you can consider this medication as well. So in summary, we want to identify symptoms, how they affect quality of life, and we want to review what the expected risks and benefits of treatments are with the patients. It's important to set expectations regarding outcomes. The goal should always be to reduce severity to a degree that it will not interfere with quality of life, but we shouldn't set expectations that the symptom will go away completely. It's always good practice to start with non-pharmacologic therapy or using non-pharmacological therapy in conjunction with pharmacologic agents. And referral to subspecialist providers such as palliative care and patients who have hard-to-control symptoms should be considered. And that's the end. If there's any, I don't know if there's time for questions or.
Yeah, so we have just a couple of minutes. Holly, thank you very much. I actually have 5 questions that I wrote. Obviously, we're not going to be able to get to all the questions. I would encourage people, Sherry, maybe you could say, how can people send their questions in so that we could show them to Dr. Koncicki and then get her to respond?
Their chat box to send the questions in.
Okay.
Side of your screen.
Right. And will that be the case even after we go offline, or should they email them directly to the coalition?
They can email them directly to the coalition if we don't get to them today, yes.
And what address?
It's kidneycoalition@gwu.edu.
Okay. Kidney Coalition, all one word, at gwu.edu. All right. So we have one question. Any evidence of carnitine therapy for hypotension?
I'm not sure about hypotension, though I do know that there is some evidence for carnitine in use for muscle cramps, but I'd have to look into hypotension and get back to that person.
Okay, and I would encourage people to use the chat function if they want to send a question in now while waiting. So I think we all are very familiar with how NSAIDs can help arthritis pain. And we're also very concerned about NSAIDs and losing residual renal function in chronic kidney disease. But as you point out, once they're on dialysis, if they have no residual renal function, there's the risk of GI bleeding, and you point out the risk of stroke. What about, and we know so many patients that just say they can't stay on dialysis for 4 hours because their back is killing them because of their arthritis. is the risk of stroke only if they're taking the NSAIDs daily? What about people who would only take one dose prior to dialysis, so 3 times a week? Would the risk be as high?
Right. So like this is some of the problem is that the quality of the evidence is relatively limited, right? So this was just a prospective study in which patients said that they had used NSAIDs at some point, within the 3 months prior. I would think that using NSAIDs and pre-medicating prior to dialysis, which is what I recommend for a lot of my patients, would put you at a lower risk than somebody who would be using this, several times a day on a daily basis. So I think that would be a good approach. Say, take Motrin prior to coming to dialysis to see if we can get you through the treatment.
Right. And of course, it would be an informed consent discussion. There's an increased risk of stroke. We don't know how much. Okay. Here's another question. A renal palliative care team is seeing frequent use of morphine in dialysis patients on comfort care in the hospital and in some hospice organizations. We advocate for hydromorphine as best as able. Are you seeing this commonly, and how do you advocate for your patients? So what do you do about that?
So we do see it, and I feel like all of our fellows really are kind of hone in on the medications that are being given. So we try to educate the teams that we would prefer to use hydromorphone because of the risk with morphine, because morphine, the metabolites can build up and give some neurotoxicity. I think that if you're on hospice and very close to the end of life, those effects might not be as clinically significant as somebody who's going to be on morphine for, chronic pain. But I would still try to encourage the use of hydromorphone just to be safer.
Okay. And just final question, everybody always starts with recommending emollients for itching dialysis patients. Do you have any favorites or ones that have worked well for you?
I recommend Aquaphor, but even baby oil some people will use, which isn't really an emollient, but some people have said that's worked well for them. Okay.
Very good. All right. Well, please email your questions to kidneysupportivecare@gw.edu. And this should be posted online in about a week, I believe. And if you have trouble finding it, I'll also give you my email address if you didn't get the other one for sending questions, and I'll get them to Dr. Koncicki. My email address is amos, A-M-O-S-S, @hsc.wvu.edu. So one way or the other, hopefully we will be able to answer your questions. This was an excellent presentation. I especially enjoyed all the review of the evidence and the shortcomings that you described. So, and I just put my email address up online. So thank you very much, Dr. Koncicki. And why don't we just say on behalf of the coalition, we hope you enjoyed this presentation and found it informative. The webinar has been recorded and will be available on kidneysupportivecare.org in a few weeks. As you're leaving, please fill out the evaluation when it pops up. Your feedback is important. Thanks again and have a great day.